All right, let's talk about indoor air quality in hospitals. It's easy to think of it as just another utility like plumbing or electricity, but it's so much more than that. We're actually talking about a critical life safety system. In Zimbabwe, just like anywhere else, the hospital's ventilation system has one single vital job: protecting patients and the amazing staff who look after them from airborne infection.
And that's the core idea we have to start with. This one sentence right here, it shapes every single decision, every design choice, every procedure. Getting this right isn't just a nice to have, it's an absolute non-negotiable for delivering safe healthcare, period. Okay, so that's the big idea, but how do we actually make it happen on the ground in Zimbabwe? How do you achieve compliance? Well, that's exactly what we're going to break down. We'll walk you through the standards everyone uses, the specific requirements for each room, and a really clear step-by-step method to get it all done.
So here's how we're going to tackle this. First, we'll look at why this all matters and what standards are used in Zimbabwe. Then we'll dive into the room-by-room requirements, followed by a step-by-step method to get it right. We'll look at a real-world case study from UBC Hospital, and finally, we'll wrap up with the key takeaways you need to remember.
All right, first up, Zimbabwe's standards and practice. Let's look at the regulatory foundation. Now, what's really interesting here is that Zimbabwe doesn't actually have its own standalone national code for hospital ventilation. But that doesn't mean it's a free-for-all. There's a very clear, widely accepted best practice that pretty much governs every major project. So what does that look like in practice? Well, basically, all significant hospital projects in the country follow two major international standards. The first is ASHRAE Standard 170, that's from the American Society of Heating, Refrigerating, and Air Conditioning Engineers, and the second is the World Health Organization's Guidelines on Infection Prevention and Control. And listen, this isn't just some informal gentleman's agreement. This approach is the accepted benchmark for getting approval from the Ministry of Health, from local authorities, and from international development funders. These are the documents that set the rules. Okay, now for the really technical stuff, the blueprint, if you will. We're going to dive deep into the room-by-room requirements. And this is super important because, as you can imagine, what you need for a busy waiting area is completely different from what you need for a sterile operating theater.
So let's start where the stakes are literally life and death, critical care spaces like operating theaters and the ICU. In these rooms, the air itself becomes a medical instrument. It's a tool for infection control. The number one goal here is to prevent surgical site infections and shield the most vulnerable patients from anything nasty floating in the air.
Just look at how strict these requirements are. For an operating theater, you need at least 20 air changes per hour. That means the entire volume of air in the room is replaced every 3 minutes. The room has to be under positive pressure to push germs out, and the air coming in must be HEPA filtered. That stands for high-efficiency particulate air. And this is key, you cannot recirculate the air. Now, the ICU is similar, maybe 12 to 15 air changes, also positive pressure, but the filtration can sometimes be a little different, though HEPA is always what you want to aim for.
This concept of pressure control is absolutely fundamental. Let's break it down. Think of positive pressure, like in an operating theater, as creating an invisible protective bubble. When you open the door, air rushes out, pushing any potential contaminants away from the patient. Negative pressure, which you'd find in a lab, does the complete opposite. It's like a gentle vacuum, pulling air into the room so that nothing hazardous can escape. It contains the threat.
Okay, moving on from critical care to the inpatient areas. Think general wards, maternity units, and so on. Here, the focus kind of shifts. It's now a balancing act between basic infection control and making sure patients are comfortable. But, and this is a big but, we have to make absolutely sure that any sources of contamination, like those dirty utility rooms, are completely sealed off from the patient areas. So for a typical ward, you're looking at maybe 6 to 8 air changes an hour with a neutral or maybe slightly positive pressure for comfort. But now, look at the dirty utility or sluice room and the toilets. This is where the rules get ironclad. These spaces must always be under negative pressure, no exceptions. They need at least 10 air changes an hour, and 100% of that air has to be pumped directly outside. No recirculation. This is how you stop bad smells and, more importantly, germs from spreading. And now for our last major category, the labs. In these specialized areas, there is one goal that trumps everything else: containment. Simple as that. Whatever is being worked on inside that lab, whether it's a biological agent, a chemical, whatever, it has to stay inside that lab. For the really high-risk labs, like microbiology or the PCR labs that do DNA testing, the rules are absolutely non-negotiable. You need strong negative pressure, constantly pulling air in. You need a high number of air changes, and 100% of that air gets exhausted safely to the outside.
And the most critical rule of all, no recirculation. Not a single bit. Ever. That is the cornerstone of biosafety. Okay, so we've covered the what, all the numbers and rules. But now let's talk about the how. Because knowing the standards is one thing, but actually building a system that meets them is a whole different ballgame. So we're going to walk through a really practical 8-step roadmap that takes you all the way from the first sketch to keeping the system running for years.
These first 4 steps are really the foundation of your entire design. You've got to get this part right. It all begins with painstaking detail. You classify every single room based on its function and risk level. Once you have that map, you can define your pressure cascades, how the air is going to flow. Then you figure out how to keep your HVAC systems separate so you're not mixing air from a lab with air from an office. And only then do you calculate the exact airflows needed for every space.
So let's just make sure we're all on the same page with that term, pressure cascade. What is it? Well, it's just a fancy way of saying a planned one-way street for air. Let's go back to that operating theater suite. The theater is at the highest pressure. The scrub room next door is a little lower. The corridor outside is lower still. That difference in pressure creates a cascade that guarantees air always flows from the cleanest spot outwards to the less clean spots. It can never flow backwards. Okay, the last 4 steps are all about execution and making sure the system works for the long haul. You select the right filters, like specifying a certain MERV rating, which just measures how effective a filter is, and you install the right sensors and alarms to keep an eye on everything. Then comes a huge one, commissioning and testing. So many projects fall down here. You have to physically test that the system works as designed. And finally, remember that compliance doesn't stop when the builders leave. You need a solid plan for operation and maintenance to keep it that way.
Right, so that's the theory. But what does it look like in a real project here in Zimbabwe? Let's take a look at the UBC Hospital and see how all these principles are put into practice floor by floor. Here we are on the ground floor. This is a busy place. You've got the emergency department, triage, outpatient clinics. The big challenge here is managing all that foot traffic. The design is all about controlling the direction of the air, making sure it flows from the public waiting areas towards the clinical spaces, and then gets exhausted. It's a smart way to stop infections from spreading right at the front door. Now, let's head up to the clinical floor. This is a perfect real-world example of that pressure cascade we were just talking about. See the operating theater suite? That whole area is the heart of the design here. It's kept at a strong positive pressure, which creates that protective bubble we mentioned. Clean, HEPA-filtered air is constantly flowing out of the theaters, into the support areas, and then into the corridors. It makes it physically impossible for dirty air to get in. And last but not least, the laboratory floor. Think of this whole area as a high-tech containment zone. You can see the specific labs for microbiology and PCR. They're designed as negative pressure rooms, so all the air from the corridor is constantly being pulled into these labs. This ensures that any potentially hazardous particles are trapped inside, where they can be safely captured and exhausted straight out of the building. Okay, we've gone through the standards, the nitty-gritty technical details, and a real-world example. So let's bring it all home. What are the big takeaways here? Why does getting this right matter so much?
Really, it all comes down to 3 huge things. Number 1, and this is the most important, it protects patients and staff from dangerous airborne infections. Number 2, on a practical level, you simply won't get your project approved or funded without it. The Ministry of Health and your funders demand it. And number 3, it means we're actually building what we're supposed to be building: safe, resilient, and future-ready hospitals for Zimbabwe. In the end, it really is that simple. This isn't just about engineering or HVAC systems. It's about patient outcomes. It's a clinical imperative. Safe air saves lives.